MALLORY syndrome is an gastrointestinal disease condition. Look at these pictures. Shows that longitudinal muscle tear at the gastroesophageal junction. Look at this. Detail going on. Introduction. MALLORY syndrome is a gastrointestinal condition characterized by mucosal lacritutions at the gastroesophageal junction, often leading to upper gastrointestinal bleeding. It is usually precipitated by severe retching, vomiting, or forceful coughing and can range from mild self-limiting cases to life-threatening hemorrhage. Definition. MALLORY syndrome is defined as a longitudinal muscular tear at the gastroesophageal junction or gastric cardia, typically associated with upper gastrointestinal bleeding following episodes of retching or vomiting. Etymology. The condition was first described in 1929 by American physicians G. Kenneth Mallory and WEISS, who identified this syndrome in patients with forceful vomiting leading to upper GI bleeding. Hence, it was named MALLORY syndrome. Epidemiology accounts for 5 to 10% of all cases of upper GI bleeding, most common in adults between 40 to 60 years. Men are affected more frequently than women, 2:1 ratio, commonly associated with alcohol abuse and conditions causing severe retching. Types. While not classically divided into types, can be categorized based on 1. Acute MWS, sudden mucosal tear due to an acute precipitating event, example vomiting. 2. Chronic recurrent MWS, rare with repeated tears due to ongoing risk factors, example alcoholism, chronic cough. Causes. Forceful or prolonged vomiting. 1. Alcohol abuse, major risk factor. 2. Severe coughing or straining. 3. Seizures with vomiting. 4. Iatrogenic causes during upper GI endoscopy, cardiopulmonary resuscitation, or gastric intubation. Risk factors: 1. Chronic alcohol consumption. 2. Hiatal hernia. 3. Eating disorders, example bulimia nervosa. 4. Severe gastroesophageal reflux disease. 5. Use of aspirin or NSAIDs. 6. Middle-aged male predominance. Complications: 1. Upper GI hemorrhage. 2. Hypovolemic shock due to severe blood loss. 3. Recurrent bleeding episodes. 4. Rarely perforation or death if untreated. Pathophysiology. Step-by-step pathophysiology of Mallory-WEISS syndrome. 1. Triggering event: severe itching, vomiting, coughing, puffing, seizure, or straining increases intra-abdominal pressure. 2. Rise in intra-abdominal pressure, forceful contraction or abdominal and diaphragmatic muscles against a closed glottis leads to a sudden spike in intragastric pressure. 3. Increased pressure at gastroesophageal junction. The gastroesophageal junction is anatomically a weak zone where esophageal mucosa meets the gastric mucosa. During itching, sharing forces act to this junction. 4. Mucosal tearing. The sudden pressure surge causes longitudinal mucosal lacerations at the gastrointestinal junction or gastric cardia. Tears are usually superficial but may involve submucosal arterioles. 5. Vascular injury. Disruption of submucosal arteries, veins, bleeding into the esophageal lumen. The degree of bleeding depends on the depth of the tear and size of vessel ruptured. 6. Clinical manifestations. Bleeding presents as hematemesis, vomiting bright red blood or cough, ground material associated with dizziness, pallor, or even hypovolemic shock in severe cases. 7. Resolution or progression. In most patients, bleeding is self-limiting and heals spontaneously. In some, persistent bleeding requires endoscopic or surgical intervention. In summary, vomiting, retching, sudden intra-abdominal or intragastric pressure, mucosal tear at gastroesophageal junction, rupture of submucosal vessels, upper GI bleeding. Signs and symptoms. 1. Hematemesis, vomiting blood, bright red. 2. Melena, black cherry stools. 3. Abdominal pain or epigastric discomfort. 4. History of severe retching, vomiting, or coughing before onset. 5. Weakness, dizziness, pallor from blood loss. Diagnosis. 1. History and physical exam. Vomiting followed by bleeding. 2. Endoscopy. Gold standard. Visualizes mucosal tears and bleeding site. 3. Blood tests. CBC low hemoglobin, hematocrit, coagulation profile. Imaging rarely needed unless complications suspected. Nursing diagnosis. 1. Risk for fluid volume deficit related to blood loss. 2. Acute pain related to mucosal lacerations. 3. Anxiety related to illness and bleeding. 4. Knowledge deficit regarding conditions and prevention. 5. Risk for shock due to ongoing hemorrhage. Medical management. 1. Stabilization, IV fluid, blood transfusion if needed. 2. Endoscopic therapy first line. Injection therapy, epinephrine, thermal coagulation, homeostatic clip, band ligation. 3. Medications. Proton pump inhibitors, PPIs, antiemetics to control vomiting. 4. Surgery, rare, reserved for uncontrolled bleeding. Nursing management. 1. Monitor vital signs, blood pressure and signs of hypovolemic shock. 2. Maintain IV access and administer prescribed fluid, blood products. 3. Monitor intake, output and laboratory volumes. 4. Provide comfort and reduce anxiety. 5. Educate patient on avoiding alcohol, vomiting triggers and NSAIDs. Treatment options: 1. Conservative management, fluid replacement, PPIs, rest. Most cases resolve spontaneously. 2. Endoscopic treatment, injection, thermal coagulation, hemoclips. 3. Angiographic embolization. In cases where endoscopy fails, 4. Surgical repair, rarely required. Psychosocial medicine. 1. Counseling on lifestyle modification, alcohol cessation, stress reduction. 2. Support groups for alcohol use disorders or eating disorders. 3. Patients and family education on early recognition of GI bleeding. 4. Psychological support to reduce anxiety and fear. 5. Nutritional guidance for safe eating habits and prevention of vomiting. Prevention: 1. Limit alcohol intake. 2. Manage GERD and chronic cough. 3. Avoid forceful vomiting. Seek early treatment for nausea. 4. Avoid overuse of NSAIDs and aspirin. 5. Lifestyle changes, balanced diet, stress management. In conclusion, Mallory-Weiss syndrome is an important cause of upper gastrointestinal bleeding, often linked to forceful vomiting and alcohol abuse. Most cases resolve with supportive and endoscopic management, but severe bleeding may require advanced interventions. Prevention through lifestyle modification, early recognition, and patient education plays a crucial role in reducing recurrence and complications. Thank you. Have a nice day.